Today we are going to discuss pain management during labor. Childbirth pain signals that the time of birth is near. Pain is a subjective and individual experience, and each client's response to the pain of labor is unique. Safety for the mother and fetus must be the nurse's primary consideration when planning pain management measures. At the completion of this lesson, we should be able to examine factors that influence pain during labor and compare non-pharmacological and pharmacological nursing interventions that assist with labor. There are many factors that influence pain. There are three basic types of pain in childbirth. The first type of pain is associated with muscle contractions as the cervix is opening or dilating. The second type of sensation is a feeling of intense pressure as the baby gets lower and pushes on the muscles in the pelvis. The third type of pain is a feeling of burning or stretching as the vagina and skin stretch. Some physical factors that affect pain sensation are cervical readiness, fetal position, fatigue, and nursing interventions. Psychosocial factors include culture, previous experience, childbirth preparation, and the client's personal support system. The fear, tension, pain cycle developed in the 1920s to describe how fear causes increased pain during childbirth. As fear and anxiety increase, muscle tension increases and pain increases. To help reduce pain during labor, the nurse can reduce fear by educating the client about what is happening and reducing tension by promoting relaxation. There are many non-pharmacological pain management techniques that help reduce anxiety, fear, and tension, which are major contributing factors to pain in labor. Childbirth education, which are classes that clients take during pregnancy to learn about labor, patterned breathing techniques, and newborn care. Some other relaxation techniques include aromatherapy, music, low lighting, active birthing positions, and hydrotherapy. Effleurage is a technique that uses light, gentle, circular stroking of the abdomen in rhythm with breathing during contractions. Using sacral counterpressure by placing the heel of your hand to apply consistent pressure to the sacrum to counteract lower back pain. Pharmacological pain management includes analgesia and anesthesia. Pain medication alleviates pain sensations or raises the threshold for pain perception. Analgesia provides pain relief while still allowing the client to sense contractions. Anesthesia eliminates pain perceptions by interrupting the nerve impulses to the brain. Opioid analgesics act in the central nervous system to decrease the perception of pain without the loss of consciousness. The most common opioid analgesic used is fentanyl. The client can receive opioids via IM or IV during the early part of active labor, but the intravenous route is recommended because the action is quicker. Nurses need to educate their clients that opioid use can cause drowsiness. It is important to instruct clients to call for help with ambulation. Opioid use can have adverse effects causing decreased fetal heart rate variability, nausea and vomiting, sedation, or neonatal respiratory distress if given too close to delivery. Prior to administering opioid analgesics, the nurse must verify labor is well established. When administering opioids, the nurse must monitor maternal vital signs, contraction pattern, and fetal well-being. Be prepared to administer antiemetics as prescribed for nausea and vomiting, and assess for adverse reactions, and be prepared to administer Narcan for respiratory distress. An epidural block consists of a local anesthetic, bupivacaine, along with an analgesic, morphine or fentanyl, injected into the epidural space at the level of the fourth or fifth vertebrae. This eliminates pain from the level of the umbilicus to the thighs, relieving the discomfort of uterine contractions, fetal descent, and stretching of the perineum. However, this might not remove pressure sensations. It is administered when the client is in active labor and dilated to at least 4 centimeters. Continuous infusion or intermittent injections can be administered through an indwelling epidural catheter. An epidural block can cause fetal bradycardia, maternal itching, and maternal hypotension. Maternal hypotension is the most common adverse effect on an epidural block. The labor nurse must be prepared to administer ephedrine to increase the blood pressure, position the client on her left lateral side, increase the IV fluid, and give oxygen. Sometimes multiple doses of ephedrine are necessary. Prior to a client receiving an epidural block, the nurse will administer a bolus of IV fluid to help prevent the expected maternal hypotension. The labor nurse will also assess maternal vital signs, contractions, and fetal heart rate patterns, as well as placing the client in a left side lying position to promote circulation and oxygenation. The nurse will also insert a Foley catheter and provide client safety. A spinal anesthesia block consists of a local anesthetic, bupivacaine, injected below the spinal column directly into the spinal fluid, often in combination with an analgesic such as fentanyl. The spinal block eliminates all sensations from the level of the nipples to the feet. It is commonly used for a cesarean birth. A low spinal block can be used for a vaginal birth, but is not used for labor. A spinal block is administered in the late second stage or before a cesarean birth. Maternal hypotension is the most common adverse effect associated with a spinal block. Other potential adverse effects include fetal bradycardia, bladder and uterine atony after birth, and a potential headache from spinal fluid leak at the puncture site. For a client who receives a spinal block, the nurses will monitor maternal vital signs, manage maternal hypotension, assess level of anesthesia, numbness, provide client safety, and perform interventions to manage a spinal headache if one develops. Best nursing actions and management of postpartum spinal headache is to keep the client supine in a dark room, give PO analgesics, caffeine, and fluids. General anesthesia is rarely used for vaginal and cesarean births when there are no complications. General anesthesia is used when there is a delivery complication, emergency, or if a client has a contraindication to nerve block anesthesia. General anesthesia produces unconsciousness. Nursing actions include monitoring maternal vital signs, ensuring client has been NPO, applying SCDs to prevent DVTs, and assess the client post-delivery for decreased uterine tone, called uterine atony, which is the primary cause of postpartum hemorrhage. It is extremely important to facilitate bonding between mom and the newborn as soon as possible. In summary, there are many factors affecting pain during labor, including uterine contractions, cervical dilation, and pressure from the fetus. Management of labor pain is a major goal of intrapartum nursing care. Two approaches to manage labor pain include non-pharmacologic and pharmacologic. There are a variety of non-pharmacologic methods of pain management during labor that evidence-based research prove are very effective. The most common pharmacological methods of pain management include opioids, epidural and spinal nerve blocks, and general anesthesia when necessary.